I'm Sanjita. I'm one of the ID Micro reggers. And just a quick kind of overview about Heal COVID, which I'm sure everyone already knows, and also the associate PI scheme, which is how I've been involved with. So yeah, just a quick overview on Heal COVID and then the associate PI scheme. Could you see my slides moving?
Yes, we can.
Yeah. Okay, perfect. So essentially it's a study done sponsored jointly by Cambridge University Hospital and the university. As we all know, a lot of research and there's a lot of treatment into the acute complications of COVID, but less so on, the convalescent post-discharge phase of COVID. But there's a lot more research emerging on, the cardiovascular thrombosis and pulmonary complications. So the main aim of the study is to evaluate treatments in the convalescent phase of COVID. So at the moment, it is an open-labeled, multi-center randomized platform clinical trial to evaluate 3 arms at any given point against standard of care. At the moment, it's apixaban 2.5 milligrams twice a day for 14 days, or atorvastatin 40 milligrams once a day for 12 months, or standard of care. And the primary objective being to see whether any of these interventions have an effect on longer term mortality and morbidity. And secondary objects being to see whether there is, first of all, treatment specific, and also is there a difference in patient reported outcomes, and is there and also to quantify the cost effectiveness of treatment. Again, so the inclusion criteria is essentially anyone who's above 18 years, who's got an hospital estimated discharge date within 5 days, confirmed COVID, and also informed consent. And exclusion criteria is mainly related to any adverse effects or hypersensitivity to any of the trial medications, and also, I guess, clinical discretion in terms of if any of the medications would put patients at significant risk if they were to take part in the trial, and also kind of more sick palliative patients who would not be expected to survive 14 days post-discharge. So the reason why apixaban and atorvastatin were chosen is because COVID-19 has been associated with a very prothrombotic state, with arterial thrombosis seen more than venous sinus thrombosis, and with endothelial dysfunction being playing a causative role. So in terms of exclusion criteria for apixaban specifically, if they've got any significant bleeding, if they've got chronic liver disease, pregnancy or breastfeeding, coagulopathy, if there's any conditions like GI ulcerations or malignancies that would increase the risk of bleeding, and also if they were already on anticoagulations for non-COVID reasons. Similarly, atorvastatin was chosen because in order to try and ameliorate the endothelial dysfunction that's seen in most COVID patients. And again, the exclusion criteria for that would be, again, chronic liver disease, biochemical abnormalities like liver transaminases being 5 times the upper limit of normal, or creatine kinase being 10 times the upper limit of normal. And again, certain medications, and also if they're already on statin pre-COVID. So outcomes is, I think what's really good about the study is the fact that, most of it is done remotely and digitally. So, none of the patients would have to come into hospital. So they look at hospital-free survival, 12 months post follow-up, and then the secondary outcomes being, all-cause mortality, any adverse reactions, and any hospital readmissions post-discharge, and also patient-reported outcomes, because there's a lot more known about, like, long COVID. So I think a lot of these patient-reported outcomes is trying to quantify that and see whether any of the treatments have an effect. So a combination of seeing how tired they are, how much breathlessness affects their life, how much have they got back to their baseline pre-COVID, and we know that especially in people who've been to ITU, anxiety, depression, post-traumatic stress disorder can all play a huge role. So all these questionnaires take into account all of that, which is quite good. And then, what I said, interim analysis, I think, is planned at 3 months, and then primary endpoint at 12 months, and follow-up is all done remotely. And this is just as I've updated, I think, of mid-September. So you can see the Royal Infirmary is doing quite good. Well done us. Well, more you guys. But we're in the top recruiting sites. And I'm just going to talk a little bit about the Associate PI scheme, which is what I'm doing at the moment. And it's really open to anyone. Nurses, doctors, any allied healthcare professionals. And in order to gain that kind of recognition is you have to be involved at a local engagement over 6 months, and it's mainly to do with recruiting of patients, so eligibility, screening, randomization is the main area which I think they want involvement in. And also on the NIHR website, there's a few learning courses and objectives which you have to go through over the 6 months. And in terms of, I think there's advantages all around, to trainees, other than the love of research. There's also great understanding of clinical research and also formal recognition of research activity, and hopefully to the research team, it's hopefully helpful for recruitment and eligibility, but I guess you guys can tell me. And then in terms of in relation to Heal COVID, I'm not sure whether this happens with other associate PI schemes, but we've been having the plan is to have regular meetings with other associate PIs around the 4 nations, and it's been organized by Cambridge, and we've had 1 meeting so far, and the lead investigator, I think Mark Toshner, came and gave a talk, which was good. And I think the plan is to have a series of meetings to talk about Heal COVID, but also talk about research and clinical trials in general. And I just thought I'll bring up a few areas of points which the other trial centres had, and a few things that we discussed. So I think some of the people weren't sure about co-enrollment into other COVID-19 studies, but I think it's clear in the guidance that as long as there's no significant contraindications, there's no outright you can't do that, which is good. And then I think a lot this doesn't happen in NHS Lothian, but a few of the trusts, I think down in England, they have been discharging patients with low molecular weight heparin for COVID, just not so they weren't on any anticoagulations pre-admission, but it's been in some of their guidance that they've been discharging people with low molecular weight heparin just kind of as a prophylaxis. So I think Mark Toshner's been involved in a few cases where that's been the case, and they have discussed with the clinicians about in terms of whether they can stop that and be included in the trial, because there's not much evidence for low molecular weight heparin to be for patients with COVID to go home on, and I think they've had some success with that and recruited those people to the study. And another thing that was brought up was uncertainty about consent and recruitment of patients with lacking capacity, which I think there's good guidance on the website again for that. Another thing that some of the trial centres have had issues with is delay in trial medications being released, which has meant that patients couldn't be recruited into the study. So the ways in which they got around that was either have them labelled already on the ward rather than getting up from pharmacy, or they've been couriering it to patients as well. And one which, again, a few centres and which I've had experience here at the Western is some patients have been not been that keen about being on atorvastatin for 12 months. And I think a few had not participated because of that. So those are the main areas which were highlighted by the other trials, which I thought would be interesting to bring up. And that is all that I've had to say. Does anyone have any questions, thoughts?
Do you know how your recruitment is going at the Western?
So at the moment, not very well. So in the last, I don't have exact figures, but in the last 4 weeks, I think we've probably only recruited one.
Yeah.
Sanjita, can I just ask, so I'm Alison, we've had a few exchanged messages on the group.
Yeah.
One issue that I've had a few times is technology. So the age group, I had one guy the other day who actually didn't have a smartphone altogether, and then a few have just straight away known that they wouldn't be able to do the follow-up side of things. I just wanted to ask, do you have any idea what the compliance with the app has actually been like? Are people filling it in?
So yeah, they brought this up actually. The compliance is, again, it depends. I think they said they haven't had a look at it like formally, but there's definitely a trend in the fact that they're getting more kind of feedback questionnaires from like people in their like 40s to 50s, but anyone older, they're not getting much of the patient reported outcomes. Yeah, I think that was an area they were, even though they were, I think they still want to remain kind of like digital remote, but that was one of the areas I think Mark actually said that they were working on.
Are we not doing because of the telephone? They choose when they are recruited if you do it by telephone or but it's the lead site that would do that. So some people wouldn't really have that information because it needs to be an interim analysis that they stop and have a look at.
I mean definitely the ones that are mainly doing it are that at a certain age, the kind of under 50s, but even the older ones with the option to do the tele, it's quite intense.
Yeah.
It calls for 12 weeks. And I definitely think Janet,
and I also, speaking to people around the country, I think there's a lot of COVID research fatigue, where they just feel they've spent a lot of time doing research on COVID, and I think everyone's kind of a bit fed up of it.
Did you get a sense of how they felt they were doing when you went to the associate PI meeting? I put my hand up and say I've not been to any of the investigator meetings.
I think they were there's still a large push to recruit other sites. I don't think not as well as they wanted to. There was a lot one of the things that the takeaway things from us was to see whether any other hospital sites in our within the trust, whether they can be recruited as well. So I don't think as good as they wanted to at the moment. Yeah.
Okay.
We also have very few doctors that have done their training on this site, so we've probably got about 5 in total. which, so last week with the school holidays, we had one patient that we couldn't recruit because we didn't have a delegated doctor. So it's not come up much because we've not got that high enough volume, you know, of recruitment going on. So we're actually really only covering COVID now 1 day a week. Otherwise, I think our numbers would be a lot higher.
But I also do think it's not that attractive a study to patients with, that, as you say, there's quite a lot of electronic follow-up and then the atorvastatin for a year.
I mean, the app questionnaire literally takes a young person under 5 minutes.
Yeah, no,
It's really, it's quick.
It is quick.
But the problem that, like, you've got that 5-day window to catch them. So if we're only recruiting 1 day a week, we are at a disadvantage to kind of almost predicting, you know, the one. So we just have to obviously keep an eye on numbers because we have peaked again here on this site, not by many, but we've definitely got another 2 bays that we didn't have a week ago, COVID patients. So
Sanjita, I really like that you brought up the idea of the associate PI investigation meeting. That's actually a really good idea.
Yeah, it is.
Alistair and Julia.
Yeah, no, I know, I'm thinking about it. Obviously, everyone's new to the associate PI scheme. What's your feeling about it? Honest appraisal, and I guess this is going to become a bit more routine for us as a research group, and I'd be interested to know, honestly, how we could improve things.
I found it really good because I think because you do end up, like, I guess on the ID ward, there's a lot more, I think, because we've had like recovery and all the other trials, so there's a bit more push from the consultants and a bit more that all the regs are signed up for it. And I guess being ID trainees, we're a bit more a bit more invested in the thing because we're seeing it day to day. So it's been good to kind of have that formal recognition of doing that. And I think in terms of improving, I think a thing that I would quite like to know, but it's kind of hard because of coming like after it's been set up, but like the whole kind of groundwork of how you would, you know, set up a trial and the logistics and things like that. But then, because obviously like most of us would have come through like midway rather than, because this is a relatively new thing, but I think that would be quite good to get an understanding of.
I'm thinking going forward I mean, it's slightly difficult because obviously this is a trial you're supporting. It's not in our environment, as you've very correctly said. But going forward, we're going to obviously have a number of trials starting in terms of within the emergency department and acute medicine, and it is also now a requirement, and Connor, one of our trainees on the line, that our trainees are going to have to show evidence of research activity at their annual appraisals.
Oh, okay.
So it's just how we try, I guess, make it a streamlined opportunity and a valuable opportunity for both the trial at the individual site, but also for the trainee who, you know, obviously needs to fulfil these requirements.
Yeah. I think the opportunity, I think, to be involved right at the start would be, I think, quite useful to know, like, obviously all the logistics, the legalities and all the things that I think, especially I wasn't aware of when, like, having read through the NIHR and, like, you know, obviously talking to you guys. I think that is something I think that would be quite good for, like, trainees.
Yeah.
Yeah.
Sanjita, I think at the associate PI meeting that you had for no COVID, it was all trainees. There wasn't any other HPs or nurses or anything.
No, there was a couple of pharmacists. So it was I don't think because I think one of the things that you couldn't apply for the associate PI if you already have a significant involvement in research. So obviously, like a lot of like people already in research studies and research nurses because got a significant more experience. So it's not open for anyone like that. So it was mainly like SHOs, like reggers, and but 2 pharmacists. Yeah.
Yes, I'm pleased to hear that. Because as you say, I think, you know, it's not something that I can see nurses getting into at the moment, but hopefully in the future, I think it's something that we should be definitely trying to strive towards.
Yeah.
Scott, who obviously was Forrest, and who I don't know if you've met, who's actually doing orthopaedics at the moment, has been. Hey, Connor, do you want to say something?
You've just appeared on our big screen, Connor.
Oh, did you? No, I've just been listening. It's been very informative. Well, thanks. I won't disturb you anymore.
You to sign the delegation law for 80%.
Yes.
I thought thank you, Carl, for you.
He's done his training.
I've done training. Yeah, thanks. Yeah. I'll take my camera off then, I guess.
Oh. You do your heel training as well?
Sorry, Alistair.
No, you're fine. You're fine. It's far more amusing than what I was going to say. Yeah, but Sanjita, it would be. This is obviously something that both us as a research group and also R&D and NHS Lothian need to grapple with, about how I guess we provide the opportunity to trainees across the different specialties. So I'm going to ask you if you'd be interested in being involved in maybe developing some paperwork or something that we could send to trainees when they to perhaps signal what it might involve and entail, so that they're not signing up blindly, that I suspect you and Scott have done, obviously because the scheme is new.
Yeah, no, I'd be more than happy to do that. Yeah.
That'd be really helpful. Thank you.
That's right. And I think yeah, and hopefully I'll get a bit more. We're going to have a couple more associate like PI.
Yeah.
Meetings. I think down in England, I don't know whether it's a bit more established. I got the feeling it was. So can hopefully draw on their experiences as well.
I think they obviously had much more involvement with NIHR in England than we do up in Scotland, so I think it'll be much more driven down there.
Yeah, I suspect that the research infrastructure is a little bit different. So I suspect it came through their regional research networks and down through that way, rather than there was no communication via the Scottish equivalent. So yeah, it's been kind of word of mouth.
Okay. Yeah, no, I'd be happy to do that. Thank
you. My last question before I shut up is, do you know any plans to add any other arms onto it?
Not what was said at the meeting so far, no.
Okay.